All right, so let's talk about preterm labor, PTL, okay? Preterm labor is any kind of labor that occurs before 37 weeks of gestation, okay? And like I said, our biggest concern, or one of our biggest concerns, is lung maturity in the fetus, okay? It's going back to surfactant, right? Surfactant should be coming out of the lungs at above 34 weeks. Now, we're not too sure of the true date of her last menstrual period. That 34 weeks might be 33 weeks, 32 weeks, 35 weeks. We might not know. Does that make sense? Or sometimes the development of the surfactant can be delayed. Maybe it was 35 weeks. And some doctors might wait until we don't want any kind of delivery to happen for between 34 and 37 weeks because of the lung maturity is not there. Again, surfactant is a chemical that comes out of the lungs and it prevents the lungs from being collapsed and staying collapsed. What surfactant does is it decreases the surface tension of the lungs. The lungs need to collapse, but it needs to expand again to put more air in it, and it needs to collapse and do that. If there's no surfactant, they will collapse and stay collapsed. And when the baby's born, you're not going to be able to have that baby taking a deep breath and open those lungs. So surfactant needs to be made by the lungs, and that's what our concern is, our major concern, for preterm labor. Okay. So, what causes it? Preterm labor, infection can cause that. Maybe something that came from vagina to go into the uterus to cause that. And we could also have ruptured membranes, premature ruptured membranes. Placenta abruptio, as I mentioned before, that the placenta, for some reason, spontaneous, or it mother got in a motor vehicle accident, or tripped or fell, or something like that, and part of the placenta is now being separated from the wall of the uterus. That can also stir up contractions. Multiple gestation, and other twins and triplets. When you have more babies in there, there's going to be a greater chance that they're so big that the mom can get, right? They're so big that that balloon can get. So when you have 2 or 3 babies inside there, there's going to be more things occupying the space inside the sac, and there's a greater chance that that's going to burst the bubble, so to say, right, the sac. Dehydration. This is an interesting thing. Now, dehydration. Let's go back to endocrinology. Okay. Hint, hint. Make sure you know this. Where does? Okay. Think about this. A woman is on the beach. She's, let's say, I don't know, 34 weeks pregnant, and she's on the beach, and 2 o'clock in the afternoon. And she's not drinking what she should be, okay? And it's getting hotter, and she's sweating. And all of a sudden, she starts getting contractions. Why would she be getting contractions? Okay, she's dehydrated. We understand that she's dehydrated, okay? But why would dehydration cause contractions? That's what I want to talk about. Okay, think about this. If you're dehydrated, there's going to be you need to make sure we get water back into the bloodstream. Does that make sense? Okay. How can we reabsorb water? What hormone will reabsorb water at the kidney site? Just water. It's not aldosterone. Remember, aldosterone is going to reabsorb sodium, water is going to follow. No, we don't need to increase the sodium. We just need to increase the water. Right, okay. So what happens here is that if you have a decrease in blood volume, then it's going to release, it's going to send a message to your brain to say we need to get more volume in your blood, right, more water. It's going to actually secrete a hormone called vasopressin, or better known as antidiuretic hormone, or ADH. Where does ADH come from? The brain, right. But where in the brain? Pituitary gland. Specifically, anterior, posterior. Posterior pituitary. So what's going to happen is you're going to have the posterior pituitary secrete a bolus of this ADH to try and reabsorb the water from the collecting ducts of the nephron, right? So that posterior pituitary gets overly stimulated. And because of that, two reasons. One, it's going to secrete a little bit of another hormone that comes from the posterior pituitary, which is what? Oxytocin. Oxytocin is going to get released from the posterior pituitary, but ADH also has an oxytocin-like structure that looks like it, okay? So what's going to happen is, because of, let's say, this extra amount of oxytocin that comes out, because the posterior pituitary is so activated, and because of the ADH looks a little bit like oxytocin, that this is now going to turn on receptors for oxytocin. And then what is that woman going to feel in her belly? Contractions, okay? But the contractions are due to the dehydration. She goes to the hospital. What the nurse usually will start up is, if she sees that she's a little dehydrated, they're going to start an IV on her. Just give her normal saline. And after a amount of hours or 2 hours, we notice that her contractions start dissipating. So that's why I'm saying on here, dehydration, it's not true preterm labor. But I don't want people to think over here, you're at home and your sister's starting contractions, you're thinking it's dehydration. I don't want you to pre-diagnose, because there could be something else going on. I mean, that nurse that put on the IV also checked to see if she's, bleeding in the vagina, or if there's water that's coming out. I mean, there's other things that she checked before this, all right, before calling up the doctor to see what's going on. Does that make sense? Okay. So, if they're still contracting, if she's still contracting with the IV fluids, then we're thinking of other reasons. It wasn't due to dehydration. Okay. So does that make sense? All right. It's giving you a little bit on there, but do hint. Make sure you understand that concept of someone who is dehydrated. What's the mechanism why she would have contractions if she's pregnant? Okay. All right. And there's a lot of other reasons that would cause preterm labor, but that's just a few I just want to mention. Okay. The treatment is usually bed rest. We also give them corticosteroids. The corticosteroids, if we're expecting some sort of delivery, the corticosteroids is going to eventually get to the baby, and the baby is then going to secrete surfactant at an earlier stage. So this is in hope of trying to get the lungs mature as best as possible, giving the baby the benefit of the doubt when the baby comes out, that we're giving the best treatment and the best success rate for the baby to breathe on its own. Hopefully it will make enough surfactant coming out so the lungs of the baby won't contract. All right? And it's really early on, we'll give some kind of medication to try and stop the contractions. Okay? So there's a lot of different things. I'm not trying to have you treat all this, but at least you have an idea when you walk in that you won't be surprised with what's going on with preterm labor. Okay? All right, let's talk about pregnancy-induced hypertension, PIH. Very quick about this. This happens pretty common. Basically, we have something called preeclampsia. Preeclampsia has high blood pressure. This happens usually in the 3rd trimester. Okay. You get high blood pressure. They do get edema and proteinuria. Okay. Most women do get edematous anyway, just because they're pregnant. There's an extra volume of blood that they have on their body. So they'll get edematous, swollen feet, and they may get it so much that it's in their wrist, and they get carpal tunnel syndrome. So normal edema, or edema can be normal, but when it's hooked up with high blood pressure, and we check the urine, and we check that all the time when a woman comes in just for a routine prenatal visit, they're going to do the blood pressure at every visit, and they're also going to ask them to pee, and they'll have the the urine dipstick to go in, and we'll check for proteins in there. So when you have these three things going on, we need to stop it. What usually causes this is blood vessels leading to, there's a chemical that comes, I don't want to get into it too heavy, but there's a chemical that comes out of pregnancy in some pregnancies that actually will affect the blood vessels going to the uterus. The problem is with this is that if this is left untreated, this could lead to what we call eclampsia. Eclampsia is the same things, high blood pressure, edema, proteinuria, but then they start getting seizures. That's what we don't want to see. I think I've only seen this twice, and I'm an OB/GYN, because we pick this up so often that we actually stop it to do this before it gets to this stage. Okay? So what's causing it is the pregnancy. So the pregnancy is actually causing this preeclampsia. So the best and only treatment of this is really you have to deliver. Okay? So 5% of pregnancies get this. It's idiopathic. The definitive treatment for this, for either one, is delivery. Get that placenta, get that baby out, because the pregnancy is what's causing this, and we don't want her to have seizures. If she has seizures, she's going to have all her muscles in her neck contract so much that she can't get oxygen into her lungs, let alone they can't get oxygen into the baby's lungs, okay, or the baby's blood for that matter, okay? So that's what pregnancy-induced hypertension is. You're going to see where it's preeclampsia. I'm hoping you'll never see eclampsia, but you will see for those patients who come to us too late, right? Or patients who don't go to their antenatal or prenatal visits. Okay, we need to check for those. All right, so that's what happens with that. Postpartum hemorrhage, scary thing. Okay. Postpartum hemorrhage is a greater amount of blood loss than what you expect. Blood just keeps on coming, okay? Etiology, number one reason is uterine atony, meaning that there is no tone in that uterus. That uterus, as I mentioned before, is once the baby comes out and the placenta comes out, we need to massage that uterus so that it tightens up and gets small. If it stays boggy, if it stays soft, that there's no tone there, then those blood vessels that are now open are not being constricted, and you're going to continuously get blood coming out of it. Okay? So that's what's happening with that. Retained products conception. Okay? And in other words, placenta accreted. There's still a placenta that's coming there. You reach in and we're pulling out pieces. That uterus can't contract all the way down because something inside is blocking it from getting to a small area. Okay? Or there could be some kind of maternal blood disease. Always think of that too. Von Willebrand's disease, hemophilia, all these different things might be a reason for this. And when you have massive amount of postpartum hemorrhage, which could look like this, okay, pretty dramatic. We also have to consider about disseminated intravascular coagulation, DIC. Remember, going back to DIC, make sure you understand what this happens. All right, so here's a woman. She just gave birth, right? I'm sorry, it's so graphic. But this is just a typical sign or a typical, you walk into something like this as a nurse, you know we got to do something emergency. There's too much blood going on. Okay? So that's postpartum hemorrhage. All right, so let's talk about some maternal complications. Okay? We have hyperemesis gravidarum. What does emesis mean? Like we talked about it with GI, the GI disorders, hematemesis. Hematemesis is blood when you're vomiting. This is hyperemesis. Hyper meaning you're vomiting a whole lot, and it's gravidarum. What does gravid mean? Pregnant. So here's a woman that is constantly vomiting in her pregnancy. So severe vomiting, usually during the second trimester. Don't get mixed up with this being the morning sickness that happens in the first trimester. That's a normal thing when beta-HCG levels, the pregnancy hormone, is very high. That actually stirs up the vomiting center in your brain. but it usually peaks, that hormone usually peaks about 14 weeks or so, and then it comes down. So usually by 14 weeks, they're not having that morning sickness anymore. So I'm not considering hyperemesis gravidarum as that. So after 14 weeks is now starting the second trimester. So if they're continuing to have a lot of vomiting going on, now we call it hyperemesis gravidarum. Okay, so this is not the morning sickness that you hear about in the first trimester, second trimester. All right, and because they're they try to eat, they can't get everything. Everything just comes right up. Their body's starving. Since you can't get glucose into the body, what happens is the body's now going to start to say, hey, look, I can't get glucose. We need glucose to make ATP. You don't have it? No problem. What we're going to do is start breaking down your fats. And when you start breaking down your fats, one of the byproducts is keto acids, right? We learned about that with GKA, right? So what happens is that it starts breaking down your fats, and one of the byproducts is keto acids. The keto acids will go into your bloodstream and go into the urine. But it doesn't go very high so much that in DKA, their breath smells like that nail polish or grapefruit juice kind of thing. But you do see that it occurs in the blood, and you can test that, okay? So that's what's usually happening with that. Gestational diabetes mellitus, we mentioned this before we did endocrinology and talking about diabetes, but very briefly on this, again, what happens here is that they weren't diabetic before they were pregnant. We usually check for diabetes because this occurs fairly often in pregnancy. We usually check the glucose by doing a glucose tolerance test, usually around 26 weeks of gestation. We have to drink this it tastes like Coca-Cola, but flat. So it's very rich in sugar. You drink this, and they check your blood sugars at 1 and 2 hours. If they have to go further, they got to do a third hour one. But that's what it's doing. If its levels are higher than what they expect, then you're gestational diabetic, and there's a whole slew of different things you're going to have to do, which we won't go into the details about it. But what's happening here, why do women get it, or some women get it? The placenta secretes a hormone that's going to block insulin. And some women are very vulnerable to this, and it happens so great that they get the gestational diabetes. So it blocks the insulin, so therefore no glucose can get inside the cells. Okay? So this hormone that comes out of the placenta, now think what's happening during each week of the gestation, the pregnancy. As the baby grows, the placenta grows. As the baby grows, the placenta grows. So this placenta gets bigger and bigger and bigger, and is going to produce each week more and more and more of this hormone that's going to block the insulin. So the problem is that it's going to be very difficult to manage gestational diabetes, because what's good at this week, the following week we're going to have to up the dosage. The following week we're going to have to up the dosage. It gets higher and higher and higher. So that's what happens with gestational diabetes. And I do want you to note that 20% of women, the pregnant women who have gestational diabetes, not the child that is born to that, but the mother, 20% of them become diabetic later on in their own life. So we're looking at 1 in 5 women who have gestational diabetes become a diabetic themselves later on. So they're at high risk. So once they have gestational diabetes, they will always get checked every year for diabetes for the rest of their life, because they're at a 20% risk of getting diabetes themselves. Okay? Okay, last thing I just want to do is ectopic pregnancies. Okay? Ectopic just means an abnormal site. All right? So we have your uterus, the vagina, fallopian tube, okay? This is all connected. You have your ovary here. And normally what happens here, the penis goes in here into the vagina, never where the uterus is. Okay? Sperm goes this way. So you have a little sperm. It goes this way, it goes right through here as usual. The egg pops out of the ovary and goes this way. The egg and sperm unite, and usually the biggest bend of the fallopian tube, referred to as the ampulla of the fallopian tube. They unite. This then is going to travel here. It takes about 5 to 7 days to get back into the uterus, and then is going to implant in the endometrium. It wants to stay on the endometrium. Doesn't want to go into the myometrium and cause placenta preta, right? And then this thing gets big and big and big. And that's how normal pregnancy works. But in a woman where an ectopic pregnancy happens, the egg and sperm still meet up around the ampulla. But for some reason, when they unite, they stay there. They don't move back this way. So the pregnancy grows and grows. And that fallopian tube is about as thick as a straw. It can't hold a pregnancy. It's incompatible with life. So as this gets bigger and bigger and bigger, this is going to burst. And when it bursts, blood will pour all over here. This is the #1 cause of maternal deaths in the first trimester. Okay? This is not compatible with life. Most of these ectopic pregnancies, which means ectopic meaning in an abnormal place, occur in the ampulla of the fallopian tube. They can occur over here. Maybe the egg comes out here and the sperm and the egg unite at this spot. Most cases, it's in the fallopian tube, which is why a lot of times we but some people will say that they had a tubal pregnancy. An ectopic pregnancy, tubal pregnancy. Tubal meaning like in the fallopian tube. But it's most cases it's in the fallopian tube, but not all cases. Okay? But this is not compatible with life. In fact, it will kill the mother when it bursts. So we need to remove it. Okay? So in an animation, this is what's happening. All right? So the egg and sperm unite in the fallopian tube, but for some reason does not go to the uterus. Because of that, the fallopian tube bursts and they will die. I had 2 cases, very similar, so I'll just make it short and sweet with this. I had 2 cases where the mother had a possibility, or the woman had a possibility that she had an ectopic pregnancy. Now, we weren't too sure. The reason why was because she came to us in the emergency room because she had some vaginal discharge, okay? And I think she had some cramping, and on one side. Very classic kind of thing. So we did a pregnancy test, and the urine pregnancy test was positive. But you see, the urine pregnancy test doesn't tell us how pregnant she is. They just say that if you are or aren't, it's a positive or negative. But sometimes we need to get numbers, and we got to do a blood test, a beta HCG level, in other words, right? That level kind of tells us what's going on. If we get a level that's about 1,500, a blood level, we should see something with an ultrasound in the abdominal cavity. All right, not the abdominal cavity, but in the uterus. Her level, just to give you an idea, her level was at, let's say, 900. So when I did an ultrasound, and we got an official one too, the ultrasound didn't show anything. So it could be that it's just an early pregnancy, and she has a spotting going on. I just didn't know what was going on, but she was having like severe cramping. She had bleeding. We just couldn't know what's going on. So what we ended up doing was asking her, look, and it was like 3 o'clock in the morning. Why don't we wait one whole day. I need you to stay here. We'll observe you. You have these cramping going on. We do want to keep the pregnancy. And we need to know what's going on. So she decided that she wanted to go home. She signed against medical advice, because that was our recommendation, her to stay in the hospital at least until we get some other doctors to see what's going on too. Because 3 o'clock in the morning, you don't have a lot of doctors on board, right? You know, so we want to see what's going on, and get a better ultrasound and things like that. Anyway, so she went home, and then later that day, I found out that she was in bed and she died. You know, because his blood was just pouring all over. So we don't take these lightly. Ectopic pregnancy, if there's an ectopic pregnancy, we need to do something fast, okay? There are some parts, as long as they're compliant, we could have them go home, but if the symptoms don't make sense, we don't want them to go home, because we'd rather them here where the nurses could watch them all the time, and then we could watch them, and we have the doctors coming in often and do that. So that's what's going on. So this is what ectopic pregnancy looks like, at least cartoonish-wise. Also here, you can see the pregnancy over here. Now keep in mind, if we remove this, this is not considered an abortion. The reason why is because this is not compatible with life for mom or the baby. Does that make sense? All right, this is not considered an abortion. The baby's going to get big and big, and it'll burst. It's not. You can't have that happen in the tube. It's just not compatible with life. Both will die. Okay, and that's what happens. Okay, so that's the whole thing. Now it kind of makes sense, right? Maternity classes, you got to push, push, push,